Hi, Dr. Nadir. How are you?
Very good, thanks. How are you today?
Good. Thank you.
Good.
Hi, Dr. Nadir.
Hello, how are you? So, Dr. Ryan and the team, I take it you are ready?
Yes, we are ready, Dr. Nadir. Thank you so much.
Okay, thanks. So, hello everyone. Welcome to our Zoom meeting. Today, the team will be presenting 4 topics. So, Dr. Ryan will moderate the meeting. I can hand it over for you. You can start when you are ready. Thank you.
Thank you so much, Dr. Nadir. Hello, everyone. Good evening. Rian Amr from the Orange One team. We are so glad to be here today and so grateful. First of all, I would like to thank Dr. Nadir for giving us this opportunity and providing us with such a great platform to share our work. This is the first presentation for us, for the Orange One team, and we are so glad to be here today. Me and my team are very excited. As Dr. Nadir said, we have 4 topics for today in the agenda. The first topic will be about the cardiovascular diseases that will be presented by me, inshallah. And then we have the grant writing that will be presented by Dr. Aseel. And the third one will be how to use ANKI flashcards that will be presented by Dr. Chowdhury. And the last thing, of course, will be the injuries in US will be presented by Dr. Ayman. So yes, this is the 4 topics that will be presented for today. So I'll start because the first presentation is mine, and I would like to share my screen first. Just give me a minute or a second, actually. Now, can you see my screen, everyone?
Yes.
That's perfect. Okay. So today's presentation, or the first presentation, will be about the cardiovascular diseases. I can start the presentation maybe with a clinical scenario first before starting. So let's go through this clinical scenario, which says Mr. Ahmed, he is a 68-year-old man, presents to the ER with severe chest pain radiating to the left arm and shortness of breath. He has a history of hypertension, type 2 diabetes mellitus, and smoking for 40 years. His family is concerned as he has been more fatigued and less active in recent months, unable to enjoy activities with his grandchildren. As you see in this clinical scenario, it's a very common clinical scenario. We have an elderly male with multiple risk factors like hypertension, type 2 diabetes mellitus, and smoking for 40 years, and presented with severe chest pain. This clinical scenario is very common in the real life and maybe in the exams, and also during study. This is a very common clinical scenario, and you can elicit that from this scenario. This patient most probably have something in his heart, or he has cardiac issue. So the cardiac diseases are very important, and it has a very significant impact on the health or on the population. So let's go to see the significant impact of cardiovascular diseases on population, or in population. According to the Centers for Disease Control and Prevention, they have mentioned that heart disease remains the leading cause of death among older adults in the United States. In 2021, approximately 696,000 people died from heart disease, and this is a huge number, of course. That means the cardiovascular diseases have a very significant impact, and accounting for about 1 in 5 deaths. So we can say that cardiovascular diseases are really important and have a big burden. Before digging deep to the cardiovascular diseases or the pathology itself, or the classifications of the cardiovascular diseases, we can first talk about the changes that occur in the heart with aging. because the changes that occurs with age responsible for the changes or responsible for the development of the cardiovascular disease itself. So the age is an independent factor for the development of cardiovascular disease due to its effect on the heart. So there is many changes that could occur on the cardiovascular system by aging process. For instance, all of you know that the aorta contain amount or sufficient amount of elastin. During aging process, the elastin will be lost, and the aorta cannot have a sufficient amount of elastin. Decreased elastin level in the aorta itself, this will lead to arterial stiffness. So what is the issue with arterial stiffness? If there is arterial stiffness, that means the systolic blood pressure will be increased. You know that the aorta itself and the peripheral arterioles responsible for the afterload. So if there is any stiffness, the afterload will increase. And if there is any increase in the afterload, this will affect the left ventricle. And of course, it will lead to hypertrophy in the left ventricle, and the high level or the high afterload will lead to very high systolic blood pressure. And the systolic blood pressure or the hypertension itself, it could affect the left ventricle, as you know. And by time, the left ventricular hypertrophy will predispose to the ischemia. So the aging process itself predisposes to the development of ischemia or cardiovascular diseases. And also with time, the myocardial relaxation will be decreased. As I mentioned, there is left ventricular hypertrophy. That means the left ventricle could not relax normally. And this will lead, of course, to myocardial decrease in the myocardial relaxation, and of course, the development of diastolic heart failure. And if the left ventricle is very hypertrophied, that means the left atrium will contract against very stiff ventricle, and this will lead to also hypertrophy or maybe remodeling of the left atrial wall, and this will predispose for the formation or generation of atrial fibrillation foci. So it's predisposed for the atrial fibrillation also. And also with age, the beta-1 receptors that found in the heart itself, it will be less responsive. That means in elderly people, the beta-1 receptor or the adrenergic receptor that found on the surface of the heart are less responsive, and this will lead to decrease in the heart rate. And of course, if the heart rate decreased, that means the cardiac output will be decreased based on the physiological equation that all of you know, which says the blood pressure equals cardiac output multiplied by the total peripheral resistance, and the cardiac output depends on the heart rate and the stroke volume, of course. So the decreased beta responsiveness will affect the heart. This will lead to decreased heart rate and cardiac output. And of course, all of you know that we have conduction system, which is the SA node, AV node, and the bundle of his right and left bundle branch and Purkinje fibers. With aging process, all these SA nodes or all the conduction system will be affected, and this will lead, of course, to a variety of arrhythmias like sixth sinus syndrome, AV block, or even bundle branch block. So with aging, we have a variety of changes that could occur in the heart, and it will predispose for the development of the cardiovascular diseases. Well, let's continue with the same concept of cardiovascular changes. As you see here, with aging also, there is impairment in the endothelium-dependent vasodilation. You know, the coronary arteries on the heart should be dilated to increase the blood flow to the heart itself. If we have something with the vasodilation of the coronary artery, that means the blood flow to the heart will be decreased, and this, of course, will predispose to the ischemia, and this will predispose to the coronary artery disease and, of course, also peripheral arterial disease. So the aging process affects the endothelium itself, and the endothelium cannot generate nitric oxide, which is very important for the vasodilation, and this will lead to the development of ischemia and high incidence of coronary artery disease and peripheral arterial disease. Also, you know, in the aorta itself, we have baroreceptors. Baroreceptors are receptors found on the wall of the aorta, and it had the ability to detect the pressure. If we have low pressure, it will maybe the stretching will decrease, and it will activate the brainstem to activate the sympathetic nervous system and to decrease the parasympathetic nervous system in case of low blood pressure. In elderly people, the baroreceptors will not act normally, and it will be impaired. And this will lead to the development of orthostatic hypotension and recurrent falls and syncope, because they cannot maintain the tone of the blood vessels. And that means the blood pressure will be decreased all the time, or when they are trying to stand up suddenly, they will lose the ability to contract their blood vessels, and this will lead to decreased cerebral perfusion. Of course, it will lead to recurrent falls and syncope. And also, with aging, there is a decrease in exercise response. There is a decrease in maximal heart rate, cardiac output, blood flow, and the vasodilation effect. So at the end, it will lead to decreased capacity and increased cardiac complications. I would like to say something here. In elderly people, maybe they lose their ability to cope with the exercise. The exercise response will be decreased, but during rest, without any stress or without any exercise, the heart rate, the stroke volume, the cardiac output remain the same, because there is no stress on the heart, there is no increase in the cardiac work. So during rest, they have no issues, but with exercise, they have decreased exercise response and tolerance, of course. So what we have been going through is the age-related changes and its clinical implications in the cardiovascular system. I wanted to go over that because the aging itself, as I mentioned before, it's considered to be an independent risk factor for the development of cardiovascular diseases. Well, here we can see something. Clinical effect of cardiovascular changes. In older adults. As I mentioned, at rest, the heart rate, ejection fraction, stroke volume, and cardiac output will be preserved even at advanced age, because at rest there is no cardiac stress, there is no high cardiac work, so the cardiac function and remain normal. But with exercise and an illness response, of course, this will decrease with age, as I mentioned a few seconds ago. And with aging process, the peak aerobic capacity also decline progressively. The ability of the elderly people to use the oxygen to produce energy, will be decreased also. Well, as you all going with me, we have been discussing the aging process, or the age-related changes and its relation with the cardiovascular diseases. And after that, we should talk about the most important or the most significant risk factors for the cardiovascular diseases. Of course, all of you know that the cardiovascular system could be affected by the high blood pressure, by the hyperglycemia, by the high level of lipids, and by smoking. All these risk factors considered to be independent and very important risk factors to develop cardiovascular diseases. I'll deep dive in each one and talk about the significance of each one and its effect on the cardiovascular diseases. Okay. So we can start with hypertension. Of course, all of you know that the hypertension. Well, hypertension in older adults, as I mentioned before, or a few minutes ago, that in elderly people, we have very high systolic blood pressure due to stiffness of the aorta. So there is low level, or there is low content of elastin in the blood vessels, and this will lead to very high stiffness of the aorta, and this will increase the systolic blood pressure. You know, high systolic blood pressure and also the loss of elastin will affect the recoil of the aorta, and this will decrease the diastolic blood pressure. So in elderly people, we can find high systolic blood pressure and low diastolic blood pressure. And there is something called the pulse pressure, which is the difference between the systolic blood pressure and the diastolic blood pressure. So elderly people, diastolic blood pressure, elderly people have high systolic blood pressure and low diastolic blood pressure, and this will lead to high pulse pressure. So pulse pressure increases with age and reflects higher systolic blood pressure. Sometimes the systolic blood pressure will be very high and the diastolic blood pressure could be normal, and this leads to isolated systolic hypertension. All of you know that there is a diagnosis called isolated systolic hypertension in medicine. And yes, isolated systolic hypertension, dominant form in older adults, and all of you know that it can be treated with calcium channel blockers, of course. We can come to the SPRINT trial. So what is the SPRINT trial? Well, it's the systolic blood pressure intervention trial, and it's a study designed to evaluate the effect of intensive blood pressure control on cardiovascular outcomes in people or in individuals who have a very high risk. And it has been conducted between 2010 and 2015. So in the SPRINT trial, they have mentioned that intensive systolic blood pressure lowering reduces cardiovascular risk and mortality, particularly for elderly people who are equal or more than 75 years. That means if we truly and intensively lower the blood pressure, this will affect dramatically on the cardiovascular risk factors or the cardiovascular risk and mortality. So decreasing blood pressure has a very significant impact on cardiovascular diseases. And also here we have the American College of Cardiology and the American Heart Association guidelines in 2017. They have mentioned that patients with a very high or the patients who have atherosclerotic cardiovascular disease risk 10% or more should be treated with pharmacological therapy for blood pressure if the patient has blood pressure more than 130/80. So the atherosclerotic cardiovascular disease risk, it's a tool or assessment used to evaluate the cardiovascular risk in individuals who have a very high risk, of course, during or over 10 years. They have a tool or assessment method to calculate the atherosclerotic cardiovascular disease over 10 years. If the ASCVD was 10% or more, and the patient or the individual has blood pressure more than 130/80, they have concluded that the patient should receive pharmacological therapy for blood pressure. This would be mandatory to decrease the cardiovascular risk, which could be maybe like myocardial infarction, or myocardial infarction is a part of the acute coronary syndrome, maybe ischemic heart disease, or maybe stroke. So yes, people with blood pressure more than 30/80 and ASCVD 10% or more, they should receive pharmacological therapy for hypertension. Well, we can move to the diabetes mellitus. All of you know that the DM or the diabetes mellitus has also a significant impact on cardiovascular diseases. It increases the risk of cardiovascular diseases, and the diabetes particularly doubles the risk of cardiovascular disease in older adults. And Framingham study said that greater excess risk for cardiovascular disease in those more than 65 compared to younger individuals. Well, the Framingham study, it's a study that started on 1948, and it's still ongoing till now. And it provided us with a very valuable insights into the risk factors for the cardiovascular diseases, like the hypertension, the diabetes mellitus, the smoking, and the obesity. And they have also their own risk score, which called Framingham risk scores, which is scored also, it could estimate or predict the 10-year risk of cardiovascular events. And also we have the American Geriatric Society, I'm trying to use my pen. We have the American Geriatric Society recommendations. They have mentioned that, or they have said that for older adults with chronic conditions or cognitive impairment, the hemoglobin, well, this is hemoglobin. Hemoglobin A1C target should be less than 8%. Well, all of you know that the target hemoglobin A1C for diabetic patients is general. We can say that it should be less than 7%, but here they give us more space. We want it to be less than 8% because they have mentioned that elderly people who have cognitive impairment, they will have a very high risk to develop recurrent hypoglycemia. And of course, hypoglycemia will affect the brain and it can fluctuate the cognitive function also. And maybe maybe the elderly people who have cognitive impairment, they cannot detect the symptoms of hypoglycemia. So they are trying to make it more flexible or reasonable, the target of hemoglobin A1C, and to avoid the recurrent hypoglycemia in elderly people, of course. So till now, we have discussed the risk factors, the hypertension and the diabetes mellitus and their effect on the cardiovascular diseases. Sorry. We can come to the third risk factor, which is the hyperlipidemia or the dyslipidemia. Did you know that there is decreased association between the total and LDL cholesterol, the total and LDL cholesterol and the cardiovascular disease after age 80? Well, all of you know that, of course, the dyslipidemia or hyperlipidemia will lead to the development of atherosclerosis, which is the main risk factor for the ischemic heart diseases. So hyperlipidemia should be associated with coronary artery disease. But this occur after age 8, before age 80. After that, there is no association, or there is no strength in predicting coronary artery disease with high level of total and LDL cholesterol. Well, the high risk here is that low HDL, which is the good cholesterol, of course, you know, the HDL called the scavenger or the good cholesterol. If it was very low, maybe below 40 milligram per deciliter in men or below 50 milligram per deciliter in women, and high total HDL cholesterol ratio, maybe more than or equal 5.5 in men and more than or equal 5 in women, independently, this could be associated with coronary artery disease up to age 85. So high level of HDL and high level of total and HDL cholesterol ratio, these could be strongly associated with the development of coronary artery disease, but it still remain below the 85 years old. And of course, statin benefit. Statins show benefit in moderate and high-risk patients up to 85. All of you know that statin has a very strong effect on the mortality rate in people who have had ischemic heart disease. Let's go to the fourth risk factor, which also independent, very important risk factor, which is smoking. You know, smoking prevalence declines with age. Well, people tend to quit smoking when they are aging. Maybe they will stop smoking because its effect and its complications, and maybe some of them were smoking for a very long time, and after that they have developed comorbidities or any chronic conditions like the chronic obstructive pulmonary disease, and they enforced to stop the smoking. So as general, smoking prevalence declines with age, so it will decrease due to cessation, and unfortunately sometimes due to deaths, because people who tend to smoke excessively, they could have complications or diseases that could lead them to pass away, and this will be also considered a factor to decrease smoking prevalence with aging or with age. And smoking cessation in older adults decrease, of course, the cardiovascular disease. It's very obvious that smoking has a strong relation with cardiovascular diseases, and of course, smoking cessation in older adults will decrease the risk for the cardiovascular diseases. And smoking remains a strong risk factor for cardiovascular disease events in older adults, and this is also very obvious. So I guess we have been talking about the risk factors, or the independent and important risk factors for the development of the cardiovascular diseases. Let's talk about the additional risk factors. Okay, we can talk about the additional risk factors for the cardiovascular diseases, like low physical activity, which will increase the cardiovascular disease and all-cause mortality risk at all ages, of course, and the frailty, which will increase cardiovascular risk and mortality, especially after myocardial infarction. People who are very weak. Yes, they are very weak. They will have a very high risk to develop mortality, especially after myocardial infarction. And of course, we have other factors like the obesity and coronary artery calcium content that could be found on the CT scan, but they don't have any, it was unclear as cardiovascular disease risk factors in old adults. It was not clear, or it was unclear, but they have found that there is there is a connection, or there is association between the coronary artery calcium content on CT scan and the development of the cardiovascular diseases. Well, I can say that we've been talking about the cardiovascular diseases as general, and the aging process that affected the cardiovascular system. And then we walked through the independent risk factors for the development of the cardiovascular diseases. Of course, you know, the cardiovascular diseases have many divisions, like heart failure, ischemic heart diseases, valvular lesions, or maybe even cardiomyopathies. Well, these are a variety of topics. Of course, we cannot talk about all these topics in one presentation. But for me, at this presentation, we'll talk about the coronary artery diseases or the ischemic heart diseases. So let's dive into our major topic today, which is the coronary artery disease. And we can start with the epidemiology of coronary artery disease. The epidemiology of coronary artery disease, mortality after myocardial infarction increases with age, and this is very important. And the prevalence of coronary artery diseases also increase with age, both men and women. Of course, postmenopausal women will have low level of estrogen, and that will make them equal with males in the context of developing of coronary artery disease. And the angina incidence peaks at 65 to 84 years and declines after, of course. And we can say that 2/3 of myocardial infarctions occur in adults equal or more than 65 years. So 2/3 of myocardial infarction, this is a huge number, and it's associated with aging. As I mentioned earlier, the changes that occur in the cardiovascular system with aging, it will affect the ventricles, and of course, the hypertrophy of the ventricle at the end, or ultimately, it will lead to the increases of thickness of the ventricular muscle, and this will increase the risk for ischemia, of course. So yes, 2/3 of myocardial infarction occur in adults equal or more than 65 years, excluding silent myocardial infarction. Well, let's go to see the acute coronary syndrome. Well, when you hear acute coronary syndrome, of course, you will think about the most emergency situation of chest pain. All of you know the acute coronary syndrome, but I can say something. If we talked about the ischemic heart diseases, maybe we can divide it to many categories. I could say we can divide it to stable angina, but stable angina, it's not part of the acute coronary syndrome. The acute coronary syndrome, it contains the unstable angina, as you see in this slide, and that non-ST elevation myocardial infarction, and also ST elevation myocardial infarction. Well, the stable angina, it could be considered a part of the chronic coronary syndrome or chronic coronary artery disease, because in this part, all of you know that the coronary artery will be occluded maybe 70 or 75%. So at rest, the individual or the patient will be normal without any manifestations or symptoms, but when he starts to do something or to do any exercise, the chest pain will occur. So we call it stable angina, and it's a part of the ischemic heart disease, but usually the patient will develop the chest pain with exercise, and when he started to rest, the chest pain will resolve. But in acute coronary syndrome, the chest pain is severe usually, and it can occur at rest. It's not associated with exercise. So the unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction, all of them considered a part of the acute coronary syndrome in which people come to the ER complaining of a very severe chest pain. You know that in the unstable angina and non-ST elevation myocardial infarction, in the reality, both of them will be treated as the same, because in the reality, you cannot differentiate between them actually, because in the ST elevation myocardial infarction, there is total occlusion to the coronary artery. It will be occluded 100%. That means the cardiac muscle has no blood supply at all, and this will lead to CV infarction or cell death in the left ventricle, or maybe in the ventricular muscle. And this is considered as irreversible damage, the cell death. So in ST elevation myocardial infarction, you can do the ECG and you can do the cardiac troponins or the cardiac enzymes. And because this is irreversible cell death or cell injury, it means the cell will be destructed and the cardiac troponins will go out. So in the ST elevation myocardial infarction, you can find the ST elevation on ECG, of course, and of course you can find the positive cardiac troponins in the blood. But here in non-ST elevation myocardial infarction and unstable angina, well, both of them, there is no 100% occlusion of the coronary artery. Maybe both of them could be, there is an occlusion up to 90% of the coronary artery. In non-ST elevation myocardial infarction, that means the part that very far from the blood supply, which is the subendocardial area, will be affected, and this, of course, will lead to subendocardial infarction. So non-ST elevation myocardial infarction, we cannot find the ST elevation. It's called like this, of course. There is no ST elevation because there is no transmural infarction, but we have subendocardial infarction, and infarction means the tissue death. That means the cardiac troponins will start to leak out of the cell, and there will be a very high level of troponin in the blood, and that means in non-ST elevation myocardial infarction we could see, or we could find ST depression, not ST elevation, but of course there will be a very high level of cardiac troponins. And in unstable angina, of course it's angina, it means ischemia, there is no infarction, so cardiac troponins will be negative, and beside that there will not be ST elevation. So unstable angina could present with ST depression and negative troponins, but sometimes the non-ST elevation myocardial infarction could present very early and the cardiac troponins could not be positive. So in the reality, we are treating the unstable angina and then the non-ST elevation myocardial infarction as the same. And of course, the stable angina considered as a part of the chronic coronary artery disease. So the acute coronary syndrome, the unstable angina, then an ST elevation myocardial infarction, and the ST elevation myocardial infarction considered the most important and the top emergency regarding the coronary artery diseases. We can move forward and talk about the acute coronary syndrome presentation. Well, as you can see in this slide, or in this slide, chest pain declines with age, especially after 80. You can notice that the chest pain declines with aging. That means elderly people could have acute coronary syndrome, but without chest pain. That means either they have had neurons degeneration, or the degeneration of the nerves that responsible for the innervation of the cardiac muscle itself, or the involvement of the autonomic nervous system. It means that elderly people could have other issues with their nerves, so they cannot present with the pain. So instead of the pain, they can present with other symptoms. So you can see here that shortness of breath is the most common symptom in patients age 80 and 85. And I can say something else, that people, elderly people who will have ischemic heart disease or acute coronary syndrome usually could have a concurrent cardiac pathology. As I mentioned in the early slides, that aging can affect the heart, and this will lead to a variety of cardiac diseases like cardiomyopathies, maybe heart failure. So those patients could have other cardiac issues rather than the ischemic heart diseases. And once the patient started to develop or to have ischemia on top of the cardiac pathology, this will lead to depression or suppression of the action of the heart or the function of the heart, and this will lead to decreased cardiac output. And this, of course, could present with shortness of breathing. So shortness of breath is the most common symptom in patients age 80 to 85 or plus. And older patients are more likely to present with altered mental status, confusion, dizziness, or syncope. Also, elderly people could have chronic conditions like dementia or any other condition that affect the brain. So yes, they could have any concurrent comorbidities that affect the brain with ischemic heart disease, and maybe the other concurrent cardiac pathologies could affect the heart and decrease the cardiac output, and of course, based on that, it will decrease the cerebral perfusion, and this will lead to altered mental status, confusion, and dizziness or syncope. And presentation delays and altered symptoms often delay treatment initiation, unfortunately, yes. And non-diagnostic ECGs are more common in older patients. Well, as I mentioned, elderly people could have any other comorbidities, and these comorbidities or cardiac problems could affect the ECG, so their ECG could be bizarre or non-diagnostic. And this is also a big issue, and we need to treat elderly people very carefully regarding the ischemic heart diseases. Yes, well, we can see here the therapy of acute coronary syndrome. Well, the acute coronary syndrome, as I mentioned, or as you have seen in the previous slides, that we have the unstable angina, the non-ST elevation myocardial infarction, and the ST elevation myocardial infarction. Well, all of them we can use the medications to treat them, but each one has its own, or its specific method for treatment. Actually, not specific, but I could say that the ST elevation myocardial infarction, after starting the medical treatment, you should treat the patient immediately with PCI or reperfusion therapy, like doing percutaneous coronary intervention, which is the PCI. And this should be done within 120 minutes. This is very crucial, very critical, because you are trying to save the cardiac muscle, and you want to do that earlier. So the therapy of acute coronary syndrome, it includes aspirin, 160 to 325 milligram for all suspected acute coronary syndrome patients, regardless of the age. And also, you can administer oxygen to maintain arterial oxygen saturation equal or more than 92%. And you can start to give the patient sublingual nitroglycerin for ongoing chest pain. You know that you are giving patients who have ischemia sublingual nitroglycerin because it's very important, and it can lead to the vasodilation of the venous circulation, and this, of course, will decrease the venous return to the heart. And when you start to decrease the venous return to the heart, this will decrease the preload on the heart, and when you are decreasing the preload to the heart, this will help the heart to rest and decrease the cardiac work or the cardiac load, and you will just relieve or alleviate the pain easily. So yes, IV sublingual nitroglycerin for ongoing chest pain should be administered unless contraindicated. I know that all of you know in medicine, people who have right myocardial infarction should not receive IV nitroglycerin because it will decrease the preload to the heart, and in right ventricular infarction, actually the patient depend on the preload to maintain the cardiac output. So yes, you should be very careful regarding the administration of the lingual or sublingual or IV nitroglycerin. You should administer it to patients who have no contraindication. And of course, the severe chest pain due to acute coronary syndrome or myocardial infarction, you should give IV morphine if nitroglycerin is ineffective in alleviating the pain. And of course, regarding the treatment of acute coronary syndrome, class 1 recommendations, of course, antithrombotic therapy in addition to aspirin, all of you know this, and P2Y12 inhibitors like clopidogrel or ticagrelor also should be received. These drugs act on the platelets, that the thrombus that occur in the coronary artery, it has components. One of these components is the platelet aggregation. So you are trying to inhibit the platelet aggregation and prevent the propagation of the thrombus. So providing the patient with P2Y12 inhibitors will be very critical and crucial to inhibit the propagation of the thrombus, of course. And anticoagulants, of course, enoxaparin and fractionated heparin, bivalirudin, fondaparinux, and of course you will stop it after the revascularization, and avoid routine use of prasugrel and glycoprotein 2B3A inhibitors. Also, these drugs inhibit the platelet aggregation. You should avoid routine use of these drugs because it increases the bleeding risk in elderly people who are 75 or more years old. Well, you know that in the acute coronary syndrome, particularly the ST elevation myocardial infarction, the definitive treatment is reperfusion. You should restore the blood flow to the heart as soon as possible. The time is gold standard. You need to restore the blood flow as possible as you can. So for ST elevation myocardial infarction, we should use PCI immediately within 120 minutes. So here, I guess he's talking about something. Oh, sorry. In this slide, we are talking about the post-acute coronary syndrome. So if the patient had acute coronary syndrome and then the patient was stabilized, he should be treated or he should be maintained on a variety of drugs or multiple drugs. These drugs have shown to have a very significant impact on the prognosis of the ischemic heart disease or of the acute coronary syndrome. So the patient after the stabilization from acute coronary syndrome should be maintained on aspirin. It will decrease the recurrent attacks of acute coronary syndrome. Beta blockers, AC inhibitors, and ARBs, angiotensin receptor blockers, and statins if there is no indications. All of you know that beta blockers, AC inhibitors, ARBs, and statins, all of these drugs have very strong impact on the mortality in patients who have had coronary or acute coronary syndrome. And of course, the patient could be maintained also on B2Y12 inhibitors like clopidogrel, ticagrelor, or prasugrel for at least 12 months after the episode of the acute coronary syndrome for patients less than 75, because a few seconds ago, he mentioned that those drugs could have a high risk to develop bleeding in patients who are more than 75 years old. And of course, cardiac rehab or cardiac rehabilitation, you should refer the patient to structured program whenever feasible. Well, as you see, we have gone through many things. I guess the previous slides were talking about the acute coronary syndrome or the coronary artery disease, which is the most important topic in this presentation. And we have gone through the acute coronary syndrome, the subdivisions of it, and the treatment for the acute coronary syndrome. Well, in the coronary artery disease, of course, we have the acute coronary syndrome, and also we have the chronic coronary artery diseases. So let me just say here, the chronic coronary artery diseases, older patients often present with exertional fatigue or shortness of breath rather than classic angina. And more severe diffuse coronary artery disease is common. For instance, triple vessel or left main coronary artery involvement and higher prevalence of prior myocardial infarction and associated left ventricular dysfunction. Well, usually elderly people with chronic coronary artery disease usually will have a concurrent cardiac pathology. So the main presentation, as I mentioned before, will be like shortness of breathing and fatigue more than the classic symptoms of angina. And also they could have a very diffuse coronary artery disease, like such as involving three vessels or triple vessel or left main coronary artery involvement, and of course higher prevalence of past history of myocardial infarction. It will be associated with left ventricular dysfunction, and this ultimately will lead to left ventricular failure. Well, let's talk about the diagnosis of coronary artery diseases. Well, similar diagnostic approach in older and younger adults. Older adults have a higher pretest probability of significant coronary obstruction. Well, higher pretest probability, it means the patient before doing the test, he has a very high risk to have a positive test or to have the cardiovascular disease because they have already developed the coronary atherosclerosis and the coronary obstructions. Lower false positive rates and higher false negative rates. That means elderly people have already developed the cardiac pathology and the atherosclerosis, and all these changes in the heart will predispose to the development of ischemic heart disease or acute coronary syndrome. So lower false positive rates and higher false negative rates on stress test in older people. You know, you are using a stress test to diagnose the stable ischemic heart disease like stable angina. You are using the stress test to elicit the chest pain, because when you are doing exercise, the cardiac demand will increase, and of course this will lead to decreased coronary blood flow and cardiac ischemia and the development of the symptoms. Stress tests are the initial diagnostic test of choice for stable symptoms suggestive of coronary ischemia. Well, let us see here. In this slide, we can find the control risk factors to reduce the chronic coronary artery progression. Of course, strongly encourage tobacco cessation or smoking cessation has a very significant impact on decreasing cardiovascular diseases, and also prescribe Mediterranean diet, low saturated fat, high fruits, vegetables, whole grains, and encourage aerobic exercise because it enhances the circulation in general and it can decrease the progression of cardiovascular diseases. Of course, encourage 30 or more minutes of aerobic exercise 5 days per week. That would be very perfect. And of course, advise modest weight reduction for people who have had a very high body mass index, maybe 35 or more. Well, we can go right now to see the medical therapy for chronic artery disease. I'm talking about the chronic artery disease, not the acute coronary syndrome. So the chronic coronary artery disease treatment, it includes aspirin, of course, because, you know, aspirin has a good effect on, not on mortality, but it has a good effect to reduce the recurrence of the attacks or the recurrence of the ischemia. So aspirin, 75 to 162 milligram per day for all patients with chronic coronary artery disease. And of course, statin therapy, it's very crucial. Moderate to high intensity statins like atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram are recommended to reduce mortality and mesocardiac events regardless of low density lipoprotein level. And the current guidelines advise treatment based on cardiovascular risk, not cholesterol targets. And of course, the AC inhibitors recommended for people who have coronary artery disease up to 85 years. But those people who have concomitant conditions like hypertension, diabetes mellitus, and left ventricular ejection fraction less than 40%, and chronic kidney disease or peripheral artery disease to reduce mortality and morbidity. Yes, the ACE inhibitors have shown a strong effect on the mortality and morbidity in people who have ischemic heart disease, and they should be provided or they should be administered for those people unless there is any contraindications. Of course, you know, in chronic coronary artery disease, the beta blockers is essential. It's very essential. So beta blockers indicated for at least 3 years post myocardial infarction if no contraindications, and recommended for left ventricular ejection fraction equal or lower than 40%. Those drugs or those beta blockers include metoprolol, carvedilol, and bisoprolol. And of course, you know, beta blockers have shown also a significant or positive impact on chronic ischemia because it can decrease the mortality also. So it's the first line for angina symptoms and most effective anti-ischemic agents. Initially, you are using beta blockers for the symptoms of angina, unless there is any contraindication, maybe a person or a patient who have asthma or COPD, you cannot administer beta blockers. In this scenario, you should shift or you can change the beta blockers maybe for calcium channel blockers. It's also used for the treatment of chronic coronary artery disease. As you see here, you can see the calcium channel blockers. The calcium channel blockers considered first line if beta blockers are contraindicated or combined with beta blockers and nitrates. Long-acting nitrates, they are considered less effective than beta blockers or calcium channel blockers. And of course, we have another drug which is called ranulazine, which improves angina and exercise tolerance and used alone or with other medications. As I mentioned before, the acute coronary syndrome itself, we have divided into 3 parts or 3 categories: the unstable angina, then an ST elevation myocardial infarction, and the ST elevation myocardial infarction. Of course, you need to do revascularization. In the acute coronary syndrome, in the context of severe ischemia like ST elevation myocardial infarction, you should do the revascularization immediately. As I mentioned, within 120 minutes, you should do the PCI. But in the coronary artery disease, in the chronic coronary artery diseases, the revascularization could be considered if you have given the maximum therapy or the maximal medical therapy and the patient was not responsive. So at this point, you should switch to do the revascularization. So the indications for revascularization could be for symptoms unresponsive to maximum tolerated medical therapy to reduce mortality in high-risk coronary artery disease or ischemic cardiomyopathy with reduced left ventricular ejection fraction. Of course, the revascularization therapy could have complications in people who have chronic coronary artery disease. Of course, higher rates, including mortality with increasing age, especially people who are more than 80, and applies to both PCI and coronary bypass graft or the CABG. So PCI and CABG, both of them could have complications in people, in elderly people who are more than 80 years. Well, as you see in this slide, The PCI, vice versa, the bypass surgery, which is the CABG. Well, I can say there is long-term outcomes. The long-term outcomes, it's similar between the PCI and the bypass surgery. But if we see the short-term outcomes like the higher mortality rate, the complications like cognitive dysfunction, longer hospital stays and recovery times, this occur with surgery, the bypass or the CABG surgery. And the subsequent revascularization, higher need and late mortality after the PCI. In specific situations, diabetes, multivessel, left main disease, surgery may offer better outcomes than PCI or medical therapy in selected patients, as I mentioned. Well, we can talk briefly about the risk of bypass surgery. Well, bypass surgery or CABG, coronary artery bypass graft, which you are bypassing the occluded vessel and trying to use other vessel like saphenous vein or internal mammary artery. The surgery has its own complications. So the risk of bypass surgery, cognitive impairment, they have found that up to 50% of older patients experience measurable cognitive decline post-surgery. And I guess this is significant. Recovery, most recover in 3 to 6 months, with a small percentage of patients who will have persistent dysfunction. And functional decline, they said common and can be irreversible. So the functional decline is a common thing, and ultimately it could be irreversible. And the prevention after doing the surgery or the CABG, you should start the rehabilitation in the hospital and refer to structured cardiac rehab post-discharge. This is all about the risk of bypass surgery. So we are coming to the end of our meeting, or sorry, to the end of our presentation, the first presentation, sorry, my bad. And well, as a quick recap, I could try to sum up what we have discussed through the presentation. Of course, aging leads to a decline in cardiovascular reserve and alters disease presentation, treatment response, and prognosis. And of course, elderly people or older adults account for the majority of hospitalization for acute coronary syndrome. This is very important. And nearly 80% of deaths from acute coronary syndrome occur in patients aged 65 and older. So aging has a significant impact on the cardiovascular diseases as independent risk factor, as we have discussed earlier in this presentation. Current treatments for acute coronary syndrome are effective in both older and younger adults, that is true. And however, older adults face increased risk of major complications from therapeutic intervention that we have gone through in the previous or in the next in the previous slides. So this is the summary of what we have gone through during this presentation of the cardiovascular disease. And I will conclude the presentation with a quote that says, "The greatest wealth is health," by Virgil. And this will just remind us that our health is our asset, and we should take care about our health, and we should take care about patients' health. And the cardiovascular diseases are one of the most important, significant diseases that has or that have a very high impact on general populations. So thank you so much, everyone. Thank you so much for listening to me for too long. If you have any question, any comment, anything you want to add, feel free, don't hesitate. Thank you so much, everyone. Thank you, everyone.
Thank you so much for a great presentation. Any questions?
Thank you so much, Dr. Nader.
And this is excellent. Or any comments or any addition? If not, then maybe we can go to the next topic.
Yes, sure. Thank you so much. So the next topic will be about the grant writing, and it will be presented by my colleague, Dr. Aseel. Dr. Aseel, if you're ready, the floor is yours.
Hello everyone.
Hello, Dr. Aseel. Doc, can I say in the meeting? Okay. Dr. Ayman will present the fourth topic, US injuries. So, Dr. Aseel, can you share your screen? Dr. Aseel, can you hear me?
Yes, I can hear you. Can you hear me?
Yes, I can hear you. Are you able to share your screen?
No, I'm unable. Can you share it for me?
Yes, sure, no problem, of course.
Okay, thank you.
You're welcome. So, give me a second, okay. Can you see my screen, everyone?
Yes.
Okay, that's nice. So, just
Okay.
yes. Go ahead, Dr. Aseel. Thank you.
Okay. Hi everyone. It's me, Dr. Aseel. I'm going to present grant writing today. Okay, so I'm going to start with the learning objectives. We're going to discuss what is grant proposal, what are the principles of grant proposal, what are the prerequisites to writing, what are the common mistakes, and lastly, what are the types of grants and how to write a grant proposal. Okay, so first of all, the definition of grant proposal, it is a very clear, direct document. It is written by a particular organization or funding agency with the purpose of persuading the reviewers to provide you with support. Because firstly, you have an important and fully considered plan to advance a valuable cause, and because you are responsible and capable of realizing that plan. Okay, so it's this definition is defined by Artwork. Okay, now we're going to discuss the principles of grantsmanship. The written document should be very successful. It should outline everything. The system should be very clear. It should have a good idea in order to be accepted. A good idea is usually necessary, but it's not sufficient. It has to be supported by other documents, like a good plan and a good budget plan as well, and other things. Don't quit, revise, and resubmit. It has to be adjusted several times to be perfect. Okay, criteria for most grant applications, significant. It has to be very important. The study has to be important. It has to be to have really good outcomes, and it should be a new idea, something that hasn't been done before, or it should improve something that was already done. Investigators should be very clear. There should be innovation. It has to be new and innovative. The approach should be very clear and organized, as well as the environment. It should be good for the environment in which it's going to be done. Next, we're going to develop a plan. A grant proposal are direct. It should be very clear. We should begin to formulate or clarify your ideas. The ideas have to be formulated very clearly. Have to develop a specific, meaningful plan for what you want to do and why you want to do it. In order for it to be accepted, it has to be clear for the reviewers who are going to see it, and consider how your plan will achieve positive results. Okay, so you have to have a team with you in order to discuss things. Research is highly interdisciplinary and no one person can do it. In order for a research to be very successful and have good ideas and things, it has to be done within a team. Know your strengths and weaknesses, so people can cover it up for you and have interdisciplinary team. Discuss with seniors or peers who know the process very well and can help you with that. Know the grant maker. You have to research the organization so its mission aligns with your plan. So, for example, if your plan is to improve public health, the grant maker has to be interested or willing to help in that purpose. Read the organization's proposal guidelines carefully and follow them. You have to write your grant in a specific way that aligns with them. Examine sample proposals that were funded by the organization in order to be familiar with it. Make sure your proposal fits the mission of the agency and your objectives match. Make your match explicit in your written application. Okay. You have to read extensively in order to know how to write the grant. Make sure you are up to date to techniques and literature. So you have to, in order to be innovative and creative, you have to be up to date and not repeat ideas or things that were done before. You have to collect relevant data as well as manage and update it in order to come with new things. Make a checklist and mark your calendar to stay up to date and to stay on track in writing the grants. You have to make a checklist. And when in one agency, about 25% of grants were incomplete and required submitting additional information urgently, which shows that a lot of grants are usually incomplete and people forget to submit important things, and they're usually not clear. So we have to think twice before writing one. You can ask for help from seniors or other people who usually write grants. Talk to professors, mentors, and previous grant recipients and trusted advisors in your field to help you. You also have to contact the relevant grant agency person. They can give you relevant information about it, about ways to write it, or how the organization wants to see it. Okay. Let's see. Okay, so common mistakes. People usually make mistakes when it comes to unrealistic ambition. They write too much work proposed. It usually can't be done, so people have to be realistic and write things that they can do. And goals usually have to be specific, measurable, attainable, relevant, and time-bound to be good enough. Usually the goals can be not innovative or not clearly defined priorities. The second common mistake is the investigators. It can be inadequate demonstration of expertise or publication. For example, no collaborators recruited if only one person, for example, is doing it. The third common mistake is the budget. It could be unrealistic or inadequate budget justification. Of course, it's going to be rejected if no justification is written for the amount of money needed or anything that could be required. Okay, so what are the types of grants? We have research grants. These are the most, there are a lot of actually types, but these are the most common written here in this slide. Those are research grants, research training and career development. It could be individual fellowship, institutional awards, and career development awards. Small business grants, clinical research center grants, conference grants, and administrative supplements, and loan repayment programs. Here's the section of grant proposal. Before designing your grant proposal, you have to ask yourself who you are, why you're making this project, what are your aims, your goals, how you're going to do it, the methods. You have to think about how to conduct the project. You also have to think about how much, the time needed, the resources needed. Everything has to be calculated. You also have to think about the significance of the study, where you're going to be, where it's going to be published, and everything about that. So first we start with the specific aims, and then we have to state concisely the goals of the proposed research and summarize the expected outcomes. Thirdly, we list the specific objectives of the research proposal. Example, to test the stated hypothesis, create a novel design, and solve a specific problem. Then we have to think about this research strategy, how it's going to be done, the methodology and everything. And lastly, the significance. You have to explain the importance of the problem, how the proposed project will improve the scientific knowledge or clinical practice, and how the concept, methods, technologies that drive that field will be changed if the proposal aims are achieved. That is the significance of the study. Okay. We have to think about the innovation, explain how the application challenges and seeks to shift current research or practice, describe any novel concept or methodologies to be developed and any advantage over existing ones. Lastly, the approach. You have to describe the overall strategy, methodology, and analysis to be used to accomplish the specific aims. That is data collection, analyzed, interpreted, and any resource sharing plans. You have to discuss the potential problems and alternative strategies and benchmark for success. Point out of situations and materials that can be hazardous to persons and precautions to be exercised. So you don't have to list everything that can be perfect. You also have to list the downsides of it or things that can go wrong and can be corrected as well. Okay. We also have to list the progress report. It can be provided as the approach section, including beginning and end date for the period covered. You have to say, you have to keep them updated and summarize the specific aims of the previous project period and the importance of the findings and emphasize the progress made towards the achievements. Include any significant changes to the specific aims or directions. Also, a list of publications, manuscripts accepted, and the printed material should be included. Okay, slide. Okay, so always remember, don't give up. Keep on writing. Writing a grant proposal is hard work. And take reviewers' criticism seriously. Okay, thank you so much, everyone. Do you have any questions?
Thank you so much, Dr. Aseel, for this great presentation, and thank you for shedding light on such an important topic, the grant writing. Thank you so much. If there is anyone has a question or a comment or anything, feel free. Okay, if there's no comment or there's no add, well, now let's hear from Dr. Chowdhury, who will walk us through the next topic, which how to use ANKI flashcards. Dr. Chowdhury, the floor is yours. Are you ready?
Yes, I'm ready to go. Thank you very much. First and foremost, I wanted to thank Dr. Nader for organizing this opportunity for all of us, being able to collaborate and work together and staying fresh, in medicine is something that we greatly appreciate, and it wouldn't have been possible without him. And thank you very much, Dr. Ryan, and for everybody else that has attended and made this possible for us today. So the topic that I wanted to present on is how to use ANKI. I'm just trying to present my screen over here. The way that I'm going to kind of structure this presentation is going to be more or less, I'm going to go through a PowerPoint presentation, and then in the middle of the presentation, I'm actually going to go into a couple of UWorld questions, just like 2 or 3 questions, and I'm going to have ANKI pulled up right to the side of it, and I'll show you exactly how I utilize, these methods whenever I'm making ANKI cards. And then at the very end, I'm going to show you in what, in my opinion, is the most efficient and quickest way of making cards, which I think is not really shown as often online. I think this is something that is really cool, and it could really kind of optimize, your performance in regards to ANKI. So here we go. I'm just trying to see if I can share my screen over here. Okay. Is everybody able to see my screen?
Yes, we can see it right now.
Okay,
Dr.
perfect.
Chowdhury.
Perfect. So I'm going to just start off with this PowerPoint presentation, as I was saying. So here we go. First and foremost, here we go. This is how to use ANKI, okay? And just 1 second, I just want to make sure everything can be seen here. Okay, perfect. Here we go. So first and foremost, what is ANKI? ANKI is a spaced repetition software. It is created to enhance your learning and retention of information. And specifically, it's used by many students, studying for their USMLE exams. What's great about it is that it's free and it's accessible via all platforms. And actually, it's become so popular now that there's a lot of community involvement and collaboration so that you can actually use pre-made decks that people worked really hard to make that are very detailed and kind of have all of the information in one place. And it kind of really saves you from doing a lot of work. So it's something that you should definitely be open-minded to check out. The theory of spaced repetition is that, after they say that, after you learn something, within 2 or 3 days, you kind of forget all of it. So the idea of the spaced repetition is that before all of that knowledge is lost, when you learn something the first time, after 1 day, you review it. After another couple of days, you review it again. After a couple of days again, you review it again. And by the time you go through the 3rd or 4th cycle of that, the likelihood of you forgetting that information is incredibly unlikely. You will most likely be able to remember this information for a very long time. And I can give a testament to that, as I'm saying that there are certain pictures or information that I learned from ANKI years back. I'm talking 2, 3, 4 years back. If I just look at the picture, I can remember it. It instantly comes back to me, just because when you initially learn that thing, when it's fresh in your head, you are reinforcing it day by day by day, up until the point it becomes like second nature to you. So yeah, moving forward, why you should incorporate ANKI into your studying. As I was saying before, it's become very popular. The community built decks kind of made it a lot easier. And again, like I was saying, you can learn information and never forget. The downsides of ANKI, right, is that, it's time consuming. It requires a great deal of consistency. So, as I was saying before, is that the ANKI software will kind of put a schedule for you where you have to review cards every single day. And so if you miss certain days, then you're not going to be able to optimize the method of spaced repetition. So, again, this is something that is really important. You do need to be consistent with it. And it is time consuming as well, making the cards, organizing the decks. And then if you don't follow through on that, then you kind of did it all for no reason. So it is something that, takes a bit of time, and it takes a bit of dedication. But once again, if it is done appropriately, it's a game changer. And ANKI is more of a memorization tool. I think that you can use QBanks for understanding, and you can use ANKI for memorization. And used together, obviously it's synergy. 1 + 1 = 3 if you can use them both together, of course. And last point here is really important for me is to mention this, is that it should be used to supplement learning, not be the only method of your learning. Everybody that uses ANKI and performs well using ANKI is also doing their questions. And so doing the questions is the most important thing. And then supplementing that with ANKI obviously makes it a game changer. So moving forward, and from here, I guess I'm going to kind of show you guys, we're going to move into the UWorld questions, and I'm going to pull up ANKI on the left side. I'm going to kind of show you how I go through each of these ANKI methods. So first and foremost, you're going to go on this website. Link is over here. And the website is going to look something like, just one moment, I'm sorry. The website is going to look something like this right over here. So you just go and you press on download, right? And it can be downloaded based on what you have, whether it's a Windows, a Mac. You can do it with the iPhone. Unfortunately, there is a $25 fee to download it, but Android, it's free. But Mac and Windows, you can download it onto your laptop, and that's going to be the start of your ANKI. And then coming back, after you've downloaded the ANKI, I'm going to go through each of these 3 methods. Okay, this is the first one is going to be kind of reviewing. If you are making your own cards, there are 3 methods that you can use to make your own cards. This is going to be called the snipping tool method, the close method, and the picture occlusion method, right? All three of which I feel do have a benefit and definitely should be used from time to time. But the game changer really with ANKI, in my opinion, is the use of pre-made decks. Okay, there are multiple decks that have already been made that are available to everybody on the ANKI Hub, the same website that you downloaded the ANKI from. You can just go on Google and you can search for it. There's an unlimited number of decks. And I'm going to talk about some of the really common and popular decks that people use to supplement their studying. And then finally, this right over here, using the pre-made decks to do what I call the browse and search function, right? This method, the browse and search method, in my opinion, is amazing, because what we do basically in this method is you go through a question on UWorld. Let's say you get it wrong. Instead of you writing out exactly what it is that you got wrong, or you making a card out of it, you going through first aid, copy pasting, doing all of this stuff that really is consuming time, all you have to do is go into the library of a pre-made ANKI deck and search the keyword from the question that you missed, and you will get a list of all of the cards that have already been made in regards to that particular topic, and you can just add it to your deck. And basically, once you are done with the question, you can just go through the ANKI deck and you will fly through it. I mean, it really is quick, because you don't have to waste time on writing anything down and making a card deck. The deck is kind of just getting made for you as you are going through your questions. And then when you are finished with your questions, you can go straight into your ANKI deck and just review the topics that you got incorrect. Again, I know right now this seems like a lot of gibberish to everybody, but I'm going to go through exactly how this is right here in a moment. So the snipping tool method that I was talking about, and I guess from here on out, I'm going to kind of show everybody what I'm talking about. Everybody on your laptop, whether it's a Windows laptop, and I put these over here so that you can kind of see how this is done. For my computer, if I hold the Shift, the Windows button, and the letter S button, then something like this happens on my computer, where, oh, not that. Sorry about that. This right here. So this right here comes. And so, for example, I just did this, right? And my computer just took a picture of that. And then I can copy paste this picture straight into an ANKI card. And in my opinion, this really kind of optimizes how quickly you can make ANKI cards. So I'm going to go through a couple of questions here, and everyone, we can work together on these questions for the sake of the video, and we can see if it becomes a little bit easier, okay? So what you're seeing on the left over here of my screen is my ANKI. Obviously, this is not going to be the same as your ANKI is going to look. Your ANKI is going to be completely empty, because I use ANKI for several years now, and so these are all of my ANKI decks. Basically, after you make an ANKI, first thing you're going to do is you're going to create a deck. So for over here, I'm going to write down ANKI tutorial, because that's what we are using it for. And then I'm going to press on this ANKI right here, right? And then you're going to press on add. Okay. And so there are many different types, but for right now, we're going to just start off with the basic. Okay. And over here, I have a URoll deck, like just a small, it's just like 4 questions. We're just going to kind of go through these questions. And I am sorry, I don't know why this is happening. Here we go. Okay, so yeah, like just a little bit of participation from anybody, if you would like to answer with us, you can do that. But for the sake of the presentation, I can also just go through it. Here we go. So in this question, we have a 64-year-old man coming to the ED with burning midline chest pain over the last 2 hours. The ECG is revealing elevations in leads 2, 3, and AVF. We have blood pressure is getting really low, hypotensive, right? The patient is diaphoretic and his extremities are cold. JVP is elevated, right? And on auscultation, the lungs are clear and no murmurs are heard. And so this question is asking which of the following is the best next step in management of this patient. And so, you know, sorry.
I think it's the normal saline bolus.
Excellent, excellent. That is the answer. That's excellent, and that's great. You know, that's really good. That's really good. You got through it before I could even you know, analyze the question. That's really, really good. Excellent. And so yeah, that is the answer. You know, obviously the diagnosis here is going to be that, you know, you are having a right-sided MI, and as you all may know, that in a right-sided MI, you know, you want to give fluids, you know, because the hydrostatic pressure of the fluid kind of allows the passage of the blood through the pulmonary circulation. So yeah, basically, you know, in this type of a question, right? So reading through the explanation here, what I would do when I'm making a card over here, right? So as you guys can see, I have my ANKI open over here. I have my information written over here. And I think what usually happens is as you read through this, you know, question, and there's a lot of information written here. Let's say you've read through all of it and you were able to summarize it. The way that I was able to summarize this question, the main point of this question, right, is to be able to differentiate between right-sided MI and a left-sided MI, right? And obviously we were able to do that because of the leads. 2,3 AVF is telling us it's a right ventricular MI. And then being able to know the difference in the management and why we are choosing the management for each one. And so for a right-sided MI, right, you can't give them nitrates because this would reduce the preload too much, and this would result in further ischemia in the right side of the heart. So in a right-sided MI, you give fluids, but no nitrates. Alternatively, if it's a left-sided MI, you want to give nitrates, but no fluids. The reason why is because in a left-sided MI, the heart is not able to pump the blood through the circulation. So by giving more fluid, you're just going to clog up the heart even more. So in that case, you're trying to give nitrates to reduce preload, whereas in the case of a right ventricular MI, you don't want to reduce the preload. So the way that I would do this, for example, right, is something along the line of, if I would make a card, right, I would write something like, if someone has right ventricular MI, what is contraindicated and what should you get? And on this side, I would write down nitrates, contraindicated, because this can reduce preload and lead to further ischemia. And then on the bottom side, I would write down what should you give? I'm gonna write down give fluids, but no nitrates, right? So this is one way of doing it, right? Which is just making the card by entering it directly. This is a basic ANKI card, right? And then there's another way, right? So I'm going to add this and then you just add it in. There's another way to do this, right? Which is going to be doing something called a close card, okay? This close method is basically, and this is what I recommend for people making cards when you are writing text, okay? And the way you're going to do this, right, is something along the lines of this, ready? I'll write down if right ventricular MI, give fluids, but no nitrates, right? And I'll write down if left ventricular MI, give nitrates, but no fluids, right? And so what you're going to do here, right, is that you see this area here, the fluids. If you go over there and you press on these 3 dots, it actually covers it. So I'll show you what it looks like when you go through the cards, right? And this is like a great way of so I'm going to show you exactly what this kind of looks like, okay? And then over here, what I would do as well on the other side is I would use my snipping tool and I would add this entire chart to the other side of the back. And so now I'm going to make this card, okay? And so check this out. Now let's say I close this, right? And I'm going through my ANKI deck that I just made over here. This is study now. So see on one side, it's going to be saying, if someone has right ventricular MI, what is contraindicated and what should you give? As we said before, nitrates is contraindicated because it can reduce the preload and lead to further ischemia. Give fluids, but no nitrates. So for example, now let's say this was an easy card for you. Let's say you were able to answer it very, very easily. You're just going to write down good, because that means that you don't need to see it again. But let's say it was very challenging for you to remember this. You're going to click on again, and it's going to show it to you again within a minute. And so you're going to keep going through ANKI over and over and over again like this until the topics is drilled into your head. And then the next day, it's going to show it to you again. And then the day after that, it's going to show it to you again. And as it becomes more and more easy, the space between you having to see that card again is going to increase. So over here, it's going to be 4 days. At some point, it could be 21. At some point, it could be a month, depending on how easy the card is for you. So I just wanted to show everyone this closed card over here. Do you see how over here, it's kind of blanked out? So the main topic for me was to write that down, that in right ventricular MI, you give fluids, but no nitrates. In left ventricular MI, you give nitrates, but no fluids. And then this comes up on the other side of your card. And so, this is excellent. Like, this is just an excellent way of, being able to kind of write down information that you've summarized and then being able to review it in a very quick method. So I just kind of wanted to outline, some of the methods over here, but the main method, in my opinion, that you should use for your ANKI, this is the #1 method, in my opinion, is the use of, pre-made ANKI decks. And so I'm going to talk about that right over here. So again, this was an example of the snipping tool method that I talked about again. Let's say if for example, I wanted to put a picture of a disseminated TB. What is the classic chest X-ray sign for miliary TB? That's what I would have wrote on one side of the card. On the other side, I can just copy paste this picture and just paste it right in. And again, this just kind of really quickly allows me to visually look at the X-ray and then also remember the pathognomonic term that is used in the question stem. And so this is the snipping tool method that I talked about before, where you can just take a picture of the screen using the snipping tool on your device. And then the next one is the close method, which is what I just showed you right now, which is instead of using a picture, you can just blank it out, is the classic chest X-ray sign for miliary TB. And then it shows in the next page, diffuse reticulonodular pattern, millet seed appearance. The last method, when you're making cards by itself, it's something called image occlusion, right? And this is great for like diagrams and pictures, where, for example, if you have a picture of the heart anatomy over here, you can just kind of cover one of the labels and then be able to get these pictures sent to you. And then you have to be able to guess, what is the label? Did I get it correct? Did I not? And again, as you are going through each ANKI picture, if you feel that it is easy, you're going to ask for it to repeat back to you within a minute. In a longer period of time. But if you felt that it was hard, then you're going to ask it to show it to you again sooner. And so based off of this method, eventually you're going to keep seeing the card over and over and over again until you've completely mastered the topic. So talking about the use of pre-made ANKI decks, this, I believe, I just kind of wanted to give everybody an overview of, how ANKI is utilized if you're trying to make cards by yourself, because sometimes, you're going to have to make cards on your own because they're going to be very complex and you're going to have to summarize it. And so having knowledge about these other the methods that I talked about before, the snipping tool, the close, the image occlusion, it's important because you may have to make your own cards. But the majority of your ANKI use, in my opinion, should be using these right over here, using pre-made decks. So for example, I would download something called ANKI. The way that you would do that is you just go on to, Google, and you can search down ANKI V11 download. If you go to Reddit, for example, they have files that are available. I have linked a YouTube video at the end of this presentation where you can basically be able to press on this YouTube link, and all of the files are there for yourself to be able to download. So basically what I would do here is, if you can look over here, I've already downloaded it. I've pressed on this link and I've already downloaded it. This is ANKI, okay? So ANKI, right, is like a collection. We just made 2 cards, right? ANKI is a collection of like more than 40,000 ANKI cards, all based off of UWorld, First Aid, Kaplan, basically all of the resources, USMLE RX, basically every single resource that is available on ANKI to this date. And it's all organized in one place. And so the way that I do this, right, is what I'm about to talk about right now is the browse and search method. I will go to browse. And I'm going to press on the ANKI deck, right, because that's the one that we're going to be using. You're going to go to edit and you're going to select all. And the first thing that you're going to do is you're going to suspend every single one of these cards. And so what you have done here now is basically every single one of these 40,000 cards inside of ANKI has been suspended. This specific ANKI has been suspended. And so what's going to happen now, right, is that they're all gone. None of them are inside of the system. And so I'm going to show you how you can make use of this method over here. So you're going to come back over here and let's go to UWorld again, okay? And let's try to do this next question here. And I'm going to show you how this really kind of works. Okay, so here we go. Participation once again, everybody. Thank you. The following is the most appropriate treatment for this patient's incontinence. So we have a 54-year-old postmenopausal woman. She's having involuntary loss of urine. She's saying that it shows dribbling of urine when the patient coughs, and the post-void is normal. It's not high. Okay. What do we think? She's obese, right? She's postmenopausal, something that she has decreased estrogen release right now. And she has a history of cesarean delivery at the age of 30 for a pregnancy. Okay. So what are we thinking about in regards to the treatment for this patient's incontinence? So this right over here is going to most likely be stress incontinence, right? Because she probably has pelvic floor weakness, given her age. Excellent. I see from the answers, yeah, everyone is right along the has got it perfectly. Yep, very good, excellent. So the answer is going to be mid-urethral sling. And the reason why is because, she has a weakened pelvic floor from the previous pregnancies and the cesarean delivery. And then the urogenital mucosa has atrophied due to decreased estrogen levels, right? And so, basically what I would do for this card over here. So because incontinence, as you all may know, is a very, tricky topic when it comes to the USMLE. I would go to the browse function over here, right? And now what I'm going to do is I'm going to search, right, incontinence. And as you can see over here, what's happened here now is that every single topic, every single card that has anything to do with urinary incontinence has kind of showed up over here. Every single one. And what you can do is you can basically tailor-made and unsuspend each card according to the importance, right, of the urinary incontinence and how it relates to your question. So this is specifically stress incontinence. So I'm going to write down stress incontinence. And see, so now like this is a perfect card, for example, that has come up and it says a pessary, which is the answer to the question, right? So what I would do is I would right click it and I would unsuspend it. And so now what's happened is this card automatically just got added into my ANKI deck. You see how ANKI over here now has one card? It automatically got added into my deck. May include pessary is a device that is inserted into the vagina to support the uterus. It just got tossed in. You didn't have to make the card. Before I showed you how you kind of have to make a card, in this example, I'm showing you how you can go through questions and just add cards in very, very quick and very, very seamlessly. We can do another one, and I'll just show you how it kind of works, okay? So for example, this is a question, painful swelling of the right lower eyelid. Recently visited his niece who was having an upper respiratory infection, no fever, vitals are stable. There's just right eye localized swelling in the lower eye field with associated erythema and tenderness. No conjunctival injection or ocular discharge. So this over here likely is something called a sty, right? A hordeolum. Does anybody know what the treatment, the initial management for a sty is? Wonderful, wonderful, excellent, excellent. Boom. So let's say like, so now we got this, right? Again, now, for example, let's say that, you did this question and, you didn't really know what it was. Or, you don't feel really comfortable with this question, right? Instead of, reading all of it, obviously you want to read it one time, but you get what I'm saying. Instead of like really taking a lot of time to ponder on this topic, to search it up in first aid, and maybe to make your own card with it, what you can do is, again, you can just go to this browse, and you can press on this ANKI, right? And you can just search it. You can just search the word sty. And lo and behold, it's right over here, right? It's telling you everything about it. Literally everything about it is right over there. This one over here is telling you what it is. This is meibum gland. This is another question. This could be another question. This one over here is talking, this one has the answer over here, warm compressed. So what I would do is I would right click this and I would unsuspend it. Again, I would right click this and I would unsuspend it. Last question here, okay? And then I'm going to go through all the cards and show you how quickly it kind of happens. And this question is, this is a great question. I mean, basically, I'll tell you guys what's happening over here for the sake of getting through the presentation on time. This patient over here is on heparin and is having a reaction to heparin, right? As evidence to the decreased platelet count and the 5 days post-op. And they are asking basically what is the most appropriate next step in management. And so the question is essentially asking what is the management for heparin-induced thrombocytopenia. Excellent, excellent, excellent. So that is going to be the answer, right? Great. You guys are wonderful. And so basically, like, let's say for example, you didn't know this. Again, it's very, very simple. What you can do is you can come back to this browse function that we have over here, right? And you can just search it. You can just search heparin-induced thrombocytopenia. Oh, well, maybe it doesn't have it like that. Maybe it's just HIT.
Can you remove sty?
Oh, yes. Thank you. Thank you very much. Thank you very much. Thank you very much. And here we go. So and here we go. This is the card right over here. As you can see, it says, what is the recommended treatment for patients that develop heparin-induced thrombocytopenia? Discontinue heparin and begin alternative anticoagulant, which is the exact answer to this question. So again, what I would do here, I was toggle suspend, and now it's unsuspended, right? And so now coming back, so like, let's say like this was a block. Obviously, we only did 4 questions, but just to show you like, how it kind of works, right? I did 4 questions here. I didn't waste a lot of time making the cards. I just kind of went into the ANKI and I found them. And then I would study the cards right over here. And it's asking me, what is the recommended treatment? And so if you remembered it, then you would be able to really quickly just answer. You stop the heparin and you start argatroban. And boom, it all comes up right over there. And if you look at it, the UWorld slide is there. The sketchy is there. There's even links to online MedEd, right? And so let's say you didn't really feel comfortable. Let's say you forgot. You're going to press on again, and it's going to come up again. And then now you're going to go on to the next question that you got wrong. What is a likely diagnosis in a patient that presents with red, tender bump on the upper or lower eyelid? We said that this was a sty. Hordeolum, how do we treat it? We treat it with warm compress. Again, this kind of shows up again. It shows you pictures. It has, just to help you like really kind of visualize it. Let's say you didn't get it. And then it's asking you, what is the initial treatment? As we said, warm compress. Let's say you didn't get it. And then the stress incontinence. What is the treatment? It's going to be pessaries, right? Boom. And let's say you didn't get it. And again, see, so what happens is that as you go through all of your cards, it's going to repeat it to you. It's going to repeat it to you until you feel good with it. Let's say the second time you feel a little bit better. Okay, I feel good with this. It's going to be, I'm going to press good this time. Again, with this one, like, I feel good this time. It's going to keep showing it to you over and over and over again, up until the point you feel good enough and you press, I'm going to see this in 1 day, or I'm going to see this in 2 days. And then, so then what happens is the next day, you're going to do a set of your new cards that you've unsuspended, plus the old ones that you did from the previous days. Over the course of weeks, this really kind of maximizes your learning potential because you're able to retain information while also being able to understand information at the same time. So yeah, so just wanted to kind of show everybody, how I, use ANKI, in this way. And yeah, hope that was useful to everybody. We're just going to go through the rest of this presentation over here. And yeah, here we go. So as I was talking about, this was the browse and search method that I really kind of just showed everybody. Some of my final thoughts that I have in regards to ANKI is going to be that, some people do prefer to just use pen and paper, and that's completely fine. I show everyone ANKI because I think that it's a really useful tool that you should give a try to, especially if, it's something that whatever method that you're currently doing is not really working for you, then maybe this is something that's worth a try. I know a lot of people that have scored excellent scores. They've gotten great scores using just the old, pen and paper method. And if that's you, that's fine. There's a lot of people that get 270s, 260s using pen and paper. And there's a lot of people that do amazing 270s using ANKI. So, it depends on what is best suited for you. Just because everybody else is doing something doesn't necessarily mean that it is going to be what works best for you. So, hey, I just wanted to, point that out so that, this is something that people can think about. Another thing that I really kind of wanted to emphasize here is that there are some people that only do ANKI and prioritize that over questions. And that is a huge mistake, in my opinion. The number one priority that you have is to go through your questions first. And again, using ANKI to supplement your learning, but not let it be the only learning tool. Okay. And ideally, as I was talking about, a combination of all of these methods will be needed throughout your preparation. And as a final point, of course, like I recommend using the browse and search method while doing questions on tutor mode. And if you can't find a particular question in the deck, then you make a new card using the snipping or occlusion tool. Finally, I just wanted to give everybody some additional resources over here. This YouTube link over here is going to be basically, this is all of the methods that I talked about. This gentleman goes into a great deal of detail, displaying exactly how you can do all of these methods. So for example, if you wanted to go frame by frame, he kind of downloads the ANKI and then he downloads all of the extensions. He talks about exactly, how he uses ANKI. I wanted to just link this YouTube video over here in case anybody wanted to try this method. And I also linked his email, and I gave a QR code over here of his WhatsApp in case anybody wanted to get in touch with him. He's also a tutor. Specifically, if you wanted to learn more about the ANKI method, this is something that you can use over here. And on the right side over here, I have somebody that doesn't use ANKI. He actually sticks to the pen and paper method. And so obviously, if ANKI is something that is not really helpful to you and you don't find ANKI to be helpful to you, then you can get in contact with this person, and they have methods outside of ANKI that can be used for your learning and for your exam preparation. So yeah, thank you very much, everyone. I really appreciate your time and your patience for getting through this lecture. And I'll let Dr. Nader take it from here. If anybody has any questions, please.
This excellent presentation and tutorial. Thank you so much for the great details that you went through. And I hope this will be a tool that some of you might use and find useful. Thank you.
Thank you. Thank you so much.
Thank you so much, Dr. Chowdhury. That was an amazing presentation, comprehensive, and I'm really sure all of us find it useful. Thank you so much for participation. It was great.
I'm sorry.
Okay.
Yeah, thank you. I'm just trying to stop sharing. Has my screen stopped sharing? Oh, there we go. Okay.
Not yet. Okay.
Okay. Yep. I stopped.
Okay. Now you stopped sharing. Yes. Thank you so much, Dr. Chowdhury.
Sure. Thank you.
Okay. Thank you so much. Now moving to our last presentation that will be presented by Dr. Ayman. It's about the injuries in US. Dr. Ayman, if you are ready, the floor is yours.
Yeah, assalamu alaikum everyone.
Wa alaikum assalam wa rahmatullahi wa barakatuh.
Thank you, Dr. Ayman, for this opportunity. And I want to share that this is my second participation in this program. I'm always feel happy when I'm within this group because I feel like this is a talented group that everyone wants to be a part of it and learn and teach and share. And I'd like also to congratulate you, Dr. Nader, for the consistency. This is really amazing that over years you are maintaining this program. It's something amazing. So my participation today will be about the topics of injuries in the US database. I will try to make it smooth and light because we are reaching to the end. And here we are going to talk about mainly about numbers. And whenever you have something and you want to, or you have a problem and you want to highlight it, whenever you use numbers, you make people look at it. You force them to look at it and encourage them to find a solution. So we are going to see a lot of numbers here to highlight a big problems, which is injuries, which is a common thing that happens every day, not in our life, but in our medical life, like in the hospital. Always we see these injuries, I mean. Are you able to see my screen?
Yes, Dr. Ayman, we can see it clearly.
Good. Yeah, so the objective of this presentation, 1 second. Yeah, so I'm going to provide an overview of various injury categories reported in the US, and I will illustrate the impact of injuries on daily life. We will define what is preventable injuries and try to analyze causes of preventable injuries. We will explore preventable injuries related to death and highlight data trends. Let's start with a small introduction. Injuries can be divided into 3 broad categories. accidental. Other term for this is non-intentional. Other term is preventable. Second type is intentional, or you can say non-accidental. The third part, which is undetermined, let's say an undetermined intent, like other type of injuries that does not fall in the first two categories. Most of the injuries, fact, present data on preventable injuries. And our main talk in this presentation will be about preventable injuries. And I also prefer to use the term preventable rather than accidental, because accidental usually give the sense of it's something out of our hand. We are powerless in front of it, which is not true. Preventable will always give you the sense of feeling guilty. Yes, it was preventable, but it happened. So this is it can be a big debate, but yeah, preventable in a limited side. So preventable injuries account for about more than 70% of all injuries deaths in the United States. Most of the data, or all of the data that I'm going to include here in this presentation, is from the National Safety Council, which is an institute that was founded in 1913, before the First World War, and the first data was published in 1920s. And it served as a measure, like keeping this data and publishing it annually till date. It acts as a measure of progress in preventing death and injuries, and also guide for interpreting new data. So what happened and what is minute by minute? Like if I ask you what is 10 minutes for you, you would probably say it's just a fraction of a typical busy day. It goes by so fast, you may not even think about it. What will happen in 10 minutes? Maybe you are in a line waiting for your coffee, maybe you're preparing for some meeting, maybe you are chatting with your friend, maybe you are scrolling the Facebook. But here, when we are talking about preventable injuries or injuries in general, we say minute to minute. Like every minute, there is over 100 people will suffer of a preventable injuries. Every 2 minutes, there will be a death from these preventable injuries. So in these 10 minutes, while you are waiting for your coffee, there is over 1,000 people got injured. So fear is something that we have it by nature. Like we used to fear from many things, but fear from the right thing, I mean, directing our fear to the right thing is something not all of us do. So when we are talking about odds of dying, there is a say that Americans often worry about the wrong things, like being killed in a plane crash or being struck by lightning. But in our lifetime, we are far more likely to be killed by things we do every day, or things we don't even think about, or things that we can prevent. Yeah, so it's more wise to direct your fear toward the right place, which push you to make the preventive measures to avoid that harm. Because it is more likely to die from a preventable injury, unintentional injury, than being assaulted with a gun, and you can see the numbers. It is more likely to die from opioid overdose than electrocution, or being assaulted with, sorry. And you can see also here the numbers. It's more likely to die from a fall unintentionally than in a severe storm. It's more likely to die from motor vehicle crash than in an airplane crash. And it's telling here the number is too small to calculate. I mean, the ratio of being killed in an airplane crash. Walking down or crossing the street is more dangerous than being stung, or dangerous and more common than being stung by a bee, hornet, or wasp. So also choking on food will kill you more likely than being attacked by a dog. Bicycle crash will do the same than being killed by a firework. Drowning in a bathtub is more dangerous and more likely to harm you than in a flood. So by putting all of this, preventable injury-related death was counted in 2023 to be over 222,000 deaths. And this is just little decrease from the past year, which is 2022, by 1.9%. But if you look at the number in 1992, it shows you a big increase, huge increase, up to 154%. Preventable injury is a common big concern, isn't it? Yes, because more than 7,000 preventable injuries happen every hour, like 25 preventable deaths every hour. This is according to the NSC, National Safety Council. And looking at this chart, we're showing all leading cause of death. It's showing that, as we know, heart disease, which is presented by Ryan earlier. So I'm not the only one who's spreading the depressing news here. The number one killer, then followed by the cancer, and then come on the preventable injury. And then COVID. And during the COVID era, like 2020 and 2021, preventable injuries was number 4. But then in 2022, it comes like preventable injury become number 3. So after all of this, I think all of us formulated a definition of preventable injury, or the other term, accidental injury, in his mind. But let's put it in words so we can agree on something. Yeah, like this one. Preventable injury refers to any harm or damage to the body that occurs as a result of an event or action that could have been avoided. And this is the most important thing, through a proper precautions, safety measures, or behavioral changes. So where we have been and where we are headed. As we said earlier, preventable death are often labeled as accidents. Like, it gives you the thing that you want to wash your hand. It's not your problem. It's happening. It's accident. But when you know that it's preventable and it's avoidable, you will change your mind. Eliminating preventable death within our lifetime. Is it possible? Yeah, we can say that. You can say that, yes. I mean, for yourself, you can say yes by following the rules, by doing all the preventable measures, following certain behavioral changes. Yes, I can't say yes but, at the level of the country, but yes, we can say yes at some point. But the current reality is preventable injuries, as we said, are the 3rd leading cause of death in the US after heart and cancer. So there is much work left to do. And this chart is showing the preventable injury-related death by sector in 2023, like more than 50% of the preventable injury-related death happening at home. Yeah, unfortunately. We think that we are safe at home, but it seems like you're safe at work more than at home. Yeah, and this is maybe some husbands decide to stay at work for a long time to avoid some injuries at home. Also, motor vehicle is a large percentage of injuries related death. But when it comes to preventable medically consulted, that means those people who injured got hospital, I mean, reached the hospital. Again, the home injuries are the most common. Public injuries also, but you can see the motor vehicle is less. Here it's maybe, let's say, 20%, and here maybe 5 or 7%. And usually looking at numbers makes you think, make theory, why this happened, or asking question, why this happened? Why are this, what is the reason behind these changes? So this is another benefit of following numbers. Okay, maybe you can say here, for example, because motor vehicle accidents, most of the people who got injured in that, they just didn't reach, they die at the scene. They don't reach the hospital. So injuries can cause death in minutes, in hours, but also months. And why is that? Because throughout the year, our daily activities change in response to seasons and weather. In the winter, we may be more likely to use candles, fireplaces, and space heaters. Therefore, home fires are more prevalent. In the summers, drowning, death are more common as we participate in more water-related activities. It makes sense. And also, this is another, like we can say, this is a result of following numbers. We came to know that by following numbers, by seeing many people died, for example, in July because of drowning. Temperature extremes also affect our health and well-being. Hypothermia is more of concern in the winter, while in the summer, heat stroke is a problem. If we want to look at the causes of preventable death, for example, based on the months of the year, as we said, during the summer, for example, from June up to mid of August, there is increase, as you can see in this chart. There is a peak increase of death from heat stroke. And you can see in the cold month, Jan and December, there is a peak death from fire and flames at home. In July, in June, when everyone want to play with water, drowning is common as a cause of preventable death. So knowing all these facts and seeing all these numbers make you think, what is the impact of preventable injury on the society? The first thing is societal cost is, it's counted in billions. The cost of unintentional injuries are huge. The burden on employers and society in general runs in the billions of dollars annually. As you can see, all these related to preventable injuries. The top 10 preventable injuries, like the examples of preventable injuries that are more common than others. You can see here, poisoning is number one. Poisoning is considered number one of preventable injuries that lead to death in 2022, followed by fall and then motor vehicle. While non-fatal injuries, fall is considered number one, and then being struck or by or against something is number two, and then being in a motor vehicle, like occupant is number 3. So this is we now talk about the preventable injuries, which is the first type of injuries. The second type is intentional injury. As you can see here, the green part is the preventable injuries. As we said earlier, it's almost around 74%. And this is 20-something, the intentional injuries. And you can divide it into 3 or 4 categories. Suicidal or intentional self-harm, or being assaulted or homicide. And then legal intervention, like when the police is chasing criminals, or operation of force, which is less in US, obviously. So key features of preventable injuries, we are coming to the end of this presentation. Avoidability. These injuries occur due to modifiable risk factors such as unsafe behavior, lack of safety equipment, or environmental hazards. Examples: falls, motor vehicle crashes, burns, drowning, and poisoning are common types of preventable injuries. What we should do is to focus on prevention, emphasizing education, engineering solutions, and enforcement of safety regulation can significantly reduce the incidence of these injuries. Take-home message: preventable injuries are a major public health concern and are often referred to as accidents. Though they are typically predictable and avoidable, together we can reduce the burden of preventable injuries and create safer environments for everyone. And thank you.
Thank you so much, Dr. Ayman, for this great, insightful and eye-pleasing presentation. Thank you so much. And we appreciate your participation also. Thank you so much.
I'm happy to do that.
Thank you so much. Well, if there is anyone has a question or a comment? If no, we have reached the end of our meeting, and I would like to hand over the floor to Dr. Nader for his closing, of course. Thank you so much, everyone.
Thank you once again, all the presenters. Just opening the floor for any updates, any questions or new ideas. I know Dr. Haifa is working on her poster, and she mentioned that she will present next week. Anybody else?
Hi, everyone. I just wanted to, hi, Dr. Nader, how are you doing? Thank you, everybody, for this meeting today. I just wanted to let everybody know that, I'm available if anybody needs any help, with any research, anything that they are doing. If you need another hand, another person to help out, complete any portion, whether it be like to write a discussion section or help you with any abstract, I'm available. My phone number is in the research fellowship group, and yep, you can just let me know, and I would very much be willing to participate and contribute in any way. Thank you.
Thank you so much for your availability and willing to help.
Thank you.
So if none, then I'd like to thank you all for attending this meeting, and thank you so much, Dr. Ryan and your team. Thank you all the presenters for great presentations, and I hope this will be helpful to you and to those who will come and look at the recording in the future. I wish you all the best, and if you have questions or comments or any new ideas, suggestions about the program, please reach out. I'll be happy to help as much as we can. You can reach me by email, call, text, and WhatsApp. Thank you so much. Have a wonderful day, and we'll see you next week. Assalamu alaikum.
Thank you so much, Dr. Nader. Wa alaikum assalam wa barakatuh. Have a nice day.
Thank you. Thank you, Dr. Nader, and all presenters. Thank you very much. Have a great one.
Thank you.
Thank you,
Thank you.
everyone.
Thank you, everybody.
Thank you so much again.
Thank you.
Dr. Nader,
Yes, go ahead, Dr. Rina.
sorry to pop in. This is my first meeting. I just received the email like yesterday. So I was wondering if I should contact my team members because I haven't received any message from them on the WhatsApp or.
So we are still in the stage of forming new teams. So it may take a couple of days to find a leader for the team, and then you will create the WhatsApp group for the team, and then you can start. In the meantime, I'd advise you to maybe look at the app and familiarize yourself with the steps. There are some videos about the fellowship or about the app, and there is a link for the big group. So if you want to reach out with any questions, we have seniors in this group and new fellows. So if you have any ideas or questions, they can help you navigate the process and the program. Thank you and
Thank
welcome.
you so much. Thank you.
Thank
Thank you
you.
so much for the opportunity.
Welcome.